next speech is very difficult to introduce, extremely difficult to introduce Professor Gamal Serour. I mean, he's the professor of professors, as they say. So Professor Serour is going to take us again through the same theme that we're talking about, and he's going to speak about the impact of ovarian surgery on future fertility. So Professor Serour, the floor is all yours.
Thank you very much, Mr. Chairman. Ladies and gentlemen, I know it is late, and I'm sure everybody is tired, and probably the blood sugar level is going down. And so I hope that you will bear with me, but I will do my best to stimulate you and share with me this presentation. It is the impact of ovarian surgery on future fertility. I have no declaration. I have no conflict of interest in this presentation. And I want to take you through the average number and the quality of eggs in women, because we do know that ovarian surgery affects the number of eggs in the ovary. And then what are the factors which are affecting the ovarian reserve in addition to ovarian surgery. And then the impact of ovarian surgery on ovarian reserve and future fertility, and then case scenarios. The ovarian surgery can certainly negatively impact on the fertility future of women through decreasing the ovarian reserve or causing adhesions resulting in mechanical infertility. So it is not only just the reduction of ovarian reserve. We all know that the number of eggs at birth is around 1 to 2 million, and at puberty it goes down to 300,000 to 400,000, and then at the age of 40 it is only 5,000 to 10,000, and then by the time you reach menopause it is only less than 1,000 eggs. And of course all eggs are not of the same quality. Some of them are good eggs, some of them are bad eggs. And the quality of the oocyte decreases with advanced age. The genetic aberration are present in 24% in women below the age of 34, and it increases up to 96% in women at the age of 40 and above. And the reason for this is because of the higher incidence of abnormalities in the microtubule and the chromosomal placement at the metaphase stage of meiosis II, and the loss of sister chromatid cohesion leading to single chromatid abnormality. And we are well aware of this curve, where with the advancing age, you get decrease in the quantity of the oocyte and increase in the number of abnormal oocytes. So you get decrease in the number and increase in the abnormal oocyte. And therefore, it is not surprising that the rate of implantation in young patients is around 20%, while in women at the age of 40 and 44 is only 6%. And this will explain the poor results which we get in IVF in advanced maternal age. Now, if we want to diagnose the ovarian reserve, all of us know either the AMH or the vaginal ultrasound for the ovarian volume and the AFC. And in the good old days, we used to use the clomiphene citrate challenge test, which we don't use anymore. So what is the average number, what is the average level of AMH? For younger women, it's around the 3 nanogram per milliliter, and at the age of 40, it decreases down to 1 nanogram per milliliter. So what is low level of AMH? If it is between 1 and 1.5, it is mild. If it is between 0.5 and 1, it is moderate. And if it is below 0.5, then it is a severe low ovarian reserve. And obviously, it's not only AMH, but also AFC, and the AFC correlate very much with the AMH. So when we come to ovarian response, which is affected by ovarian surgery, we do know that ovarian response to ovulation-inducing drugs depend upon the ovarian reserve, which deteriorate with advancing maternal age or due to previous ovarian surgery, and also other factors. And the ovarian reserve test detects the quantity rather than the quality of the follicular pool, and predict the ovarian response to stimulation, but does not predict the pregnancy rate. And of course, we know that there are several factors which are detrimental to the ovarian reserve, and among these factors is the ovarian surgery. And ovarian surgery can be either during laparoscopic ovarian drilling, and laparoscopic ovarian drilling, not laparoscopic ovarian drilling, But what causes marked reduction of ovarian reserve is the ovarian grilling. And we don't want to do grilling when we are doing laparoscopic drilling. And then, of course, resection of ovarian tissue, whether you are excising a cyst or you are doing an oophorectomy, whether unilateral or bilateral. And please, my young colleagues here, if you are doing laparoscopic ovarian drilling, it is only 4 punctures for 4 seconds using 40 watts. If you do more than this, then probably you will inflict more harm than good. Then when we come to the cystectomy or oophorectomy, certainly you take away ovarian tissue, and this would result in the reduction of ovarian reserve. So if we have a patient with of the endometriotic cyst not causing symptoms, a small size, should we remove it? Well, the studies had shown from patients with unilateral endometrioma that ovulation occurs in the opposite ovary just as good as the ovary which contains the cyst, and that the pregnancy occurs in the women who have unilateral ovarian cyst as well as in women who have normal cyst. Now, should we remove an endometriotic cyst before IVF? Studies had shown that comparing between 147 cycles where the endometrioma was removed compared with 63 cycles where the endometrioma was present and IVF was performed, and that, as you can see, the clinical pregnancy rate is the same, the miscarriage rate is the same, and the cancellation rate is the same. So there is no point of removing an ovarian cyst before doing IVF. Of course, provided it is not causing symptoms and is of not large size. Now, we know that if you decided to remove an ovarian cyst for various reasons, then certainly laparoscopic cystectomy is better than drainage and the coagulation, and there is increased chances of spontaneous pregnancy and reduced recurrence rate. However, when you are doing laparoscopic cystectomy, please remember that this cystectomy is going to affect the ovarian reserve, which goes down even in a period of 1 to 6 weeks, and it continues till 2 years and beyond this. And also similarly, the AFC as well is affected by your surgery. So please do not remove that unless you have a good ovarian reserve. Otherwise, the ovarian reserve would markedly deteriorate after doing a cystectomy. And concerning the recurrence, when we are counseling our patient, yes, though we remove the ovarian cyst, yet in some of the patients, you may get a recurrence of the cyst, which is around 4% in the first 3 months, and may increase up to 27% after a period of 2 years. If you don't want the recurrence of the cyst, then you may give post-operative GnRH analog in order to reduce the reduction, but this does not improve the pregnancy rate. On the contrary, it delays the pregnancy if you give a post-surgical GnRH suppression. Then, what is compromised ovarian reserve? This is a condition diagnosed when women have fewer eggs left in their ovaries compared to others at their age. And when you say compared to the others at their age, because 1.5 nanogram per mil for a woman who is 24 years old is different from 1.5 nanogram for a woman who is 40 years old. So that is compared with another woman of her age. And the odds of conceiving may be smaller, but certainly not impossible. And that egg count is not the only factor in getting pregnant. The egg quality is an important factor. And I just remind you of this wonderful study where they looked into the number of metaphase 2 oocytes needed to produce one euploid embryo. And it was found that to produce one euploid embryo for a woman at the age of 37, you need at least 11 mature oocytes. And furthermore, that as you advance age, then you need more oocytes. And indeed, this is also affected by the quality of the sperm in which you injected the oocyte, whether it was testicular sperm or it was an ejaculate sperm. And later on, Rodrigo and colleagues, they developed the they developed a preliminary model capable of predicting the number of oocytes needed to produce one euploid blastocyst according to the female age, was developed by the group of Rodriguez. And they indicated that at the age of 30, based on this model, at the age of 39 years old, you will require 16 metaphase 2 oocytes to produce one euploid embryo. And in this case, multiple ovarian stimulation may be needed in order to collect a large number of oocytes in elderly patients with compromised ovarian reserve. So, there are several factors which affect the choice of management of infertile patient following ovarian surgery with impairment of ovarian reserve. Well, of course, we have to consider the age of the patient, the duration of infertility, the previous treatment outcome, the cause of infertility, the compromised ovarian reserve. Is it ovarian reserve or is it mechanical infertility, and the level of ovarian reserve, and the other associated factors as severe oligoathenospermia or azoospermia. And above all is the patient choice, because we have to counsel your patient and do what suits the patient best. So, because it is an afternoon, as I said, and we are tired, so I'm going to ask you to share with me this presentation. If we have a young patient with long duration of infertility, with mild to moderate compromised ovarian reserve due to previous ovarian surgery, what should we do? Can I hear from the audience? No? Yes, sir. Sorry? Yes, ART. Thank you very much. And this patient has good prognosis with adjustment of the dose of FSH. I can give her a higher dose to produce adequate number of eggs, and she will get pregnant. And let us see another scenario. Again, another young patient with moderate to severe compromised ovarian reserve due to ovarian surgery, no matter what was the duration of infertility. What would be the answer? IVF. What's the prognosis for this patient? Even if it is short period of infertility, she has moderate to severe reduced ovarian reserve. So the answer is yes, ART, but the answer is ART, but you have that the patient will have a good prognosis if she responded well and produced at least one euploid embryo, because she has moderate to severe ovarian reserve, reduced ovarian reserve. So you give her ART, and she's a young patient. If she produces even a small number of oocytes, she will be able to produce one euploid embryo, and she has a good chance of getting pregnant. You agree or you don't? You agree? Okay, thank you. Then we go to another scenario. You have an elderly patient. She has a short period of infertility, and she has severely compromised ovarian reserve. What would you do? Sorry? Oh, thank you. I thought you would refer to me easy cases. Yes. Well, this case, yes, I would offer her ART, but I tell her she has a guarded prognosis. You know, the other one was young, and that's why I said, yes, she can have it. And the other one even was severe to moderate reduced ovarian reserve, but she was young. Yes, okay, she could have good prognosis if she produces adequate number of oocytes, and if even small number of oocytes, but the quality of the oocyte is good, therefore she has a better chance. But for this patient, she is an elderly patient, even she has short period of infertility, it doesn't matter because she has severely compromised ovarian reserve, so we do ART with a guarded prognosis. And during counseling, you have to tell her that she may need several trials of ovarian stimulation to get adequate number of oocytes to produce one euploid embryo. We have mentioned that to produce one euploid embryo at the age of 39, you need 17 metaphase 2 oocytes. And then let us take to the other scenario. You have young patient, she has short period of infertility, she has normal ovarian reserve, she has large endometriotic cyst causing symptoms with high endometriosis fertility index. What would you do? Yes, you do surgery, of course. And if this patient does not get pregnant after 6 to 9 months, what would you do? So, you will do IVF after this, right? Okay, yes, you do. But if the patient is not willing to wait for 6 to 9, for 9 to 15 months as recommended by the ASRM practice committee, should you do surgery or you go ahead and do IVF? Yes, so you will have to take into consideration the decision of the patient. Is she willing to wait for 9 months to 1.5 years, and the age of the patient at the time you are seeing her, because if she late in her reproductive age, you cannot perform this. Now, the other scenario that, sorry, I refer to the endometriosis fertility index, which was developed by David Adamson and Pasta, and the working group of the American Association of Gynecological Laparoscopy and the European Society of Gynecological Endoscopy and the ESHRI and the World Society of Endometriosis have agreed that the endometriosis fertility index is the best index for prognosis for infertile patients. So if you are doing endometriosis fertility index and you found that the endometriosis fertility index is high, then she has a high chance of getting a spontaneous pregnancy. If the endometriosis fertility index is low, then she has a very low chance of a spontaneous pregnancy. That's why in the previous case, we said you perform surgery that's provided, as I mentioned here, with high endometriosis fertility index. Because if the endometriosis fertility index was low, then of course you would not do surgery, because you know that the prognosis of surgery will be very poor. Now, another scenario, you have a young patient, he has long period of infertility with mild to moderate compromised ovarian reserve with OMA, less than 5 centimeters, not causing symptoms. What will you do? IVF. Any other opinion? Yes, certainly IVF, yes, with no surgery. Then we have another scenario. You have a young patient with moderate to severe compromised ovarian reserve with bilateral huge endometrioma causing symptoms. What can you do? Sorry? Laparoscopy? Laparoscopy, and she has severe and moderate compromised ovarian reserve. I see a different opinion, yes. Sorry? Yeah. But how are you going to get the embryos from her? Because she has huge endometriomas, so that's very difficult. And then, of course, we have infection. So I think, in my humble opinion, that in this case, you do de-roofing and drainage, followed by GnRH analog for 3 months. You reduce the size of endometrioma, and then you do ART. Why we are doing this? To avoid the risk of infection, to avoid the difficulty in retrieval of oocyte, and for the reduced risk of recurrence. So you only delayed her for 3 months, but of course, you took away this large endometrioma which is causing symptoms. And you did not remove the cyst, because if you remove the cyst, then she will end up with very low ovarian reserve, and you will not be able to retrieve oocytes from her. And then we have scenario 7. I know that you are tired from my frequent questions, but I believe this is the last one. The scenario 7. You have a patient who is more than 35 years old. She has moderate and severe compromised ovarian reserve. She had bilateral endometriotic cyst. She has multiple large fibroid distorting the uterine cavity, or another patient with the same background, but he is having adenomyosis. What would you do? Sorry? GnRH agonist. And then? Yes, the answer is ART. The answer is ART, and when you get the ART, what you are going to do with the embryos? Transfer or freeze? Yes, you have to freeze. Yes, why are we going to freeze? Because she has multiple fibroid distorting the uterine cavity. If I'm going to transfer this, she will abort, she will not get pregnant. That's why I'm freezing this, and then do the myomectomy, and then do the deferred embryo transfer. Because if you did the myomectomy, and then you waited for 3 to 6 months, and then by that time, our ovarian reserve might have gone down. So that's why we perform ART, freeze all, do the myomectomy, or the OMA, the roofing of the OMA, and then you do the deferred embryo transfer after 3 to 6 months. And if she has adenomyosis, then after you retrieve the oocyte, get the embryos, and then give her a course of 3 months of GnRH analog in order to reduce the inflammatory reaction in the uterus, which is with adenomyosis, and then you do the deferred embryo transfer. Then the question comes, when to do laparoscopic surgery for ovarian cyst in infertile patient? The patient must have normal semen, ovulation, and uterus. And there must be reasonable ovarian reserve, a high endometriosis fertility index in endometriotic patient, young female, less than 37, because if she is elderly, then you don't have too much time to wait. Infertility period less than 4 years. Proper counseling with the patient, that your patient is willing to wait for 9 to 11 to 15 months till she gets pregnant. And if she doesn't get pregnant, then you do ART. And failure or inaccessible alternative treatment, and no contraindication for laparoscopy. And of course, you have to be an expert laparoscopic surgeon, or at least you refer your patient to an expert laparoscopic surgeon. Because if I am not an expert laparoscopic surgeon, then I might do more harm than good. And then when to do IVF in this patient, if there is an associated factor of infertility, a severe oligoactinospermia, or tubal factor, or failure of expectant or surgical management, or patient with low ovarian reserve, there is no point of waiting and doing surgery, or patient who is more than the age of 37 years old, or a patient who has a longer duration of infertility, more than 4 years, or if the patient has an OMA less than 5 centimeters and not causing symptoms, or in patient with severe endometriosis with low endometriosis fertility index, or patient who is anxious not to wait for 9 to 15 months after surgery to get the outcome of your treatment, or when there is contraindication for laparoscopic surgery and you cannot perform laparoscopic surgery, or skilled laparoscopic surgeon is not available in your area and you don't have a referral system to do this. Finally, I would invite you all to the coming meeting of the IFFS, the International Federation of Fertility Society, which will be held in Tokyo under the chairmanship of Professor Uzuka, who is with us and attending our meeting. And this is going to be an excellent meeting. They have more than 2,000 abstracts submitted, and top scientists from all over the world will be there. And the meeting will be held on the 15th to 25th of January the next year. And at that time, really, I can tell you, Japan is a wonderful country to visit with all the cherry blossoms all over the place. And so you will enjoy your stay there. Thank you very much.